Hi everyone, thank you for attending our virtual dental shadower session today. We want to remind you that in order to get your hours, you will have to take a short quiz, and as long as you get 3 out of 5 points, you will earn your hours. The quiz link will be located in our link tree, which is in our Instagram bio. All right, let's get started. We are very fortunate to have Dr. Michele here for today's session. I'm handing the mic over to you. Feel free to start whenever you want.
Okay. Hi, guys. My name is Michele Nguyen. I have a Bachelor of Science and Doctor of Dental Surgery. And you can go to the next slide. Okay, so I'm an endodontist, and for my academics for college, I went to LSU. I was actually born and raised in New Orleans, and I attended there from 2007 to 2011. I went straight from college into dental school. I went to the LSU School of Dentistry, which is also in New Orleans, from 2011 to 2015. After that, I had decided that I wanted to do a GPR. And so I did the match program, and I ended up at New York-Presbyterian Brooklyn Methodist Hospital. I was planning to do just 1 year there, but they had an optional second year. I ended up taking on the second year there, which was probably one of the best decisions I could have made for myself. And then afterward, I love New York City. So I ended up staying. I went into private practice for a year and a half before I went back into residency for endo, where I attended NYU Langone Hospital, which is formerly known as Lutheran. It's in Brooklyn. And I just recently finished that program. It's a 2-year program. I finished in July of 2020. And then I went directly into private practice for an all endo practice that's also in Brooklyn Heights. I work here most of the time, about 3 days, sometimes 4. And then I also do 1 day a week at Coliseum Dental, which is in Manhattan in the city, which is a multi-specialty GP practice. Okay, next slide, please. Okay, so a little bit about choosing specialties. I think the main thing is that it's never too late. Because I did GPR, I can, talk a little bit about the considerations of doing a general practice residency. They're usually going to be in a hospital. And because they're in a hospital, you want to consider a couple of things, such as the trauma level of the hospital. For example, a trauma level 1 center will tend to have more surgeries, oral surgery, swellings. So you'll get a little bit more, of a vast, patient pool coming in. And you also want to consider if that institution for the general practice residency, if they have any other programs as well. The one I did, that hospital only had a general practice residency. There was no oral surgery or endo or pedo. And because of that, when you have one without specialties, one of the pros is that you may be able to do more cases. If the endo comes in, it's more likely going to go to you instead of, for say, an endo residency. If a patient comes in needing implants, if the attendings are comfortable with it, you're more likely to do the implants rather than it go to peri or oral surgery. And then if you do end up at a GPR that does have other specialties, one of the pros of that is that you can really get to know the residents and the attendings there, and allows you the ability to shadow the other residents and get a feel for specializing. Also, another thing is to have an optional second year, whereas my program had an optional second year, and ended up working out for me in that aspect. And you also want to consider some on-call requirements. If you're going to a GPR that might have 3 residents and you have to be on call and share that responsibility, you may be on call every 3rd day. The GPR that I went to, we had 13 residents, so it came out to only 1 to 2 times a month, which is, obviously really helpful if you're on call overnight. And then after my GPR, I went into private practice. If you go straight to private practice after dental school, this is also great. You get comfortable right away with, seeing patients, with scheduling, performing procedures within your scope. and then just knowing when to refer. And if you do go into private practice straight out, it is really important to get to know your specialist in the area, who you can refer to, just form a relationship so you can actually, learn a bit more from the other specialists in terms of what you want to do on your own. And then, of course, I get asked this question all the time: why endo? Why did I do endo? And, besides the aspect of, loving the procedure itself, wanting to save teeth, to be honest, for practical reasons, it was a lot about the lifestyle. When you're doing endo, I feel that it's easier to do a part-time versus full-time schedule. You could go in for 2 days or 3 days, or you could do 5-6 days, but it is a little bit easier to do part-time when you're not the general dentist in this scenario, when you're working on a referral basis. For me, I also liked it a bit more because of my scheduling. You're able to see less patients because you're giving more time to one person. When you're doing a molar endo and it may take you 90 minutes or so, or an hour, you're seeing less patients in a day rather than multiple fillings per day and then having to stop and do your hygiene checks. And of course, you get to be an expert in one field. I found that it was really hard to be, a super general dentist. And in this sense, it was better for me because I could hone my skills and my knowledge to one expertise. Okay, we can go on to the next slide. Okay, so the next slide, I thought it would be helpful to talk a little bit about some advice on the application process, in particular the endo process. It's a little bit different from the other specialties because we don't use, or currently the endo residencies are not using a match program. So the application process starts a bit earlier on. It's in May. It opens in May, generally around May 15th. It is a rolling admissions. So you really want to get your applications in early. If, that date opens on May 15th, you really want to get it in on May 15th or near the end of May, I would say at the latest. And that's mostly because these interviews, they start mid-June and they may run to August, but I find that every year they're starting earlier and earlier. And, if you're getting in your application mid-June, they may have already finished their cycle of interviews. And as much as you can, despite COVID and whatnot, you really want to try to visit any of the programs that you're really interested in person. It may be really hard to do if you're applying to many programs, but your top ones, you want to contact the director and see if they offer that. And that way you can, get to know the clinic, you can get to know the residents, and they are more likely to remember your face in this scenario. And also, it's super important, to show any interest in endo, whether, you're still in dental school, if there's a journal club that your school offers, any extracurricular programs. CE courses are super important. There's always a large amount of CE, especially with the annual session each year. And I would highly recommend joining the AAE. This was a recommendation that I got when I was interviewing and applying, that, they really like to see the dentists join the American Association of Endodontists. I would say it's important to shadow an endodontist, build a relationship with one. It would be great if you could get a recommendation letter from an endodontist in particular. And community service is always great. When I was applying, I was, told by my director that they preferred community service where you're maintaining something long-term rather than just one event here, one event there. And so one of the ones that I did each year was Special Olympics, and also Give Kids a Smile. Those are really, easy dental ones to join that you can see through the year, since it's always an annual event. Okay, so we can go to the next one. Oh, actually, can we go back one slide? There was a couple of things I wanted to say uh, about the residencies. So it's also important to research all the schools that or programs that you want to apply for the endo residency, because some are university based and they are more didactic research based, while others can be in a hospital setting and you may get more clinical. So it's important to know, if you want to do more research or more clinical. Some of the questions you can always ask when you're visiting or interviewing is, how many cases they're doing, how many surgeries they're doing per resident. And then also some other things to note about the programs that some are actually paid or offer a stipend. And, the majority of them do have tuition. Some of them are 3 years with a master's and others can be 2 years. So it's something to take into consideration when you start to research and decide where to apply. Okay, we can go to the next slide. Okay, so what a typical day for me is like, on average, I see about 5 scheduled treatment patients a day. I may have 2 to 3 consults on my side book, which are about half an hour. And I may have 1 to 2 emergency patients. So I typically start 8:30 and end at 5. Everything's about 60 to 90 minutes. My front desk nurse just scheduled me. Any molars are straight away 90 minutes and anteriors are 60 minutes. I also have an hour lunch, but that's typically when they're putting in any type of emergency patient that, the referrer calls and says, I need you to get someone in. And my day is going to be, a range. I see a lot of treatment through crowns, mostly molars. I'd probably say about 50% root canal versus retreats. There's a lot of calcified cases. I do surgeries. And every so often getting some children, so I'll do some vital pulp therapy or regeneration cases. One of the things that took a bit for me getting used to when I first started was the amounts of reports and phone calls you have to do with the referrers after. So when I finish at 5, I pretty much linger around the office till 6:30, even sometimes 7, just going through all the treatment reports and phone calls. I occasionally do Saturdays. I'll do a half day on Saturday a couple times a month, and that'll be a half day, 9 to 2. And then, so most common patient concerns, obviously for the patient, their main concern always is going to be feeling pain during the treatment and feeling pain after treatment, right? And so the most common provider concerns for me is also getting the patient comfortable, because most of the time these patients are coming in acute pain. And, as you know, anytime with acute pain, it can be very difficult to numb, with blocks and, just swelling that will take up a lot of the anesthesia in this case, as we call a hot tooth. For me, another concern would be my relationship with a referrer, being able to communicate with them directly during the day after treatment. Also, diagnosis. A lot of the teeth I'm seeing are through crowns. You can't, directly test all the time in this scenario. And you can also get a lot of referred pain. So diagnosis is definitely key. Some, obvious risks during treatment with separated instruments, risk of paresthesia, especially with surgeries, and then managing cracked teeth or fractures, because they can be very questionable. Even using with a microscope and a cone beam, you can't always identify if there's a crack or a fracture in the tooth. And what are the toughest parts about proposing treatment plans? Fortunately, by the time the patient sees us and they're in our chair, they already know they need a root canal and treatment. So there's minimal concern on my end for the patient to accept the treatment plan. They're ready to get the root canal done that day or the surgery. In proposing treatment plans, it's probably more important for the endodontist and the referrer relationship, because a lot of general dentists, if they're doing the root canal or if it fails, they may go directly to an implant. And, in the past, the success of Apico's using amalgam was a lot lower, and now we're using bioceramics, and technology and equipment is changing, our success rates are going higher. So it's more about speaking with a referrer, having them know that, you know, you do retreats and surgery so that they can know when to refer instead of going to an extraction and an implant. Okay, we could go to the next slide. So these are some common dental instruments used in my specialty. The first one is the cone beam. It's a Carestream 9000, and I use the cone beam for pretty much every molar, upper and lower molars, and retreats, any type of tooth that already had a root canal. The second photo is the whole rubber dam setup, includes the anesthesia on the side. I always have Vaseline now. I always put a little bit of Vaseline on the patient's lips before, because they're going to, for endo, going to be open for a long period of time with the rubber dam around. And they always really appreciate that. And then of course, articulation paper to reduce occlusion at the end. In the top right picture, I have my ProMark rotary here. Next over is the endo activator to the left, which is used to help with irrigation. And then the white on to the left of that is my Kerr down pack, which is similar to a System B. And then all to the far left, the pink is the BNL Mini, which is the backfill when I'm doing warm vertical condensation. In the bottom left picture, we have endo ice with the number 2 cotton pellet and a bite stick. These are for diagnosis. I don't have pictured the perio probe, but I also use percussion and palpation. In the middle bottom picture, there's the ultrasonic, which I use almost religiously for every case for troughing and looking for additional canals, and apex locator. And then the last picture is a global microscope, which I use for also every single case. And we can go to the next slide. Okay, so the last part of my PowerPoint, I just have a couple of cases. The first one is a complex premolar. This was number 13, 3-rooted premolar. Came in with highly symptomatic cold lingering and positive to percussion. You had distal occlusal caries that went into the pulp, and the diagnosis was irreversible pulpitis with symptomatic apical periodontitis. Some signs, you know, when you're looking for in this pre-op PA, what are some signs that can hint to you that it's a 3-rooted premolar? So you want to try to follow the PDL as much as you can. And once you start to see the canals disappear, it's always a hint, not necessarily that it's 3-rooted, but that the canals can split. So occlusally, you can clearly see the canal, and then it starts to get a little fuzzy down in the mid-root, coronal mid-root section. So that's always a hint that it's one orifice likely splitting into at least 2 canals. If you don't have a cone beam, you always want to take at least 2 PAs, that one straight on and one angled, so you can try to see if there's another root hiding behind there. Once you get past this point, if you're already opening into the tooth, what are some other signs that might hint that it has additional anatomy? One of them is that once you're cleaning and shaping, if you know the canal continues to bleed here and there, that can be a hint there may be vital tissue inside and another canal. If you get to the point of doing your working length with files or your master cone images, if you notice asymmetry where it's lying in relation to the root width, then that's also another hint when it's asymmetrical. Or sometimes I always hear this, you can see some sealer that might shoot into an additional canal. And then at that point, you may know that, you know, that it has an additional canal. Some difficulties in this case is that the mesial buccal and the distal buccal were within one orifice. So you really need high magnification, specifically a microscope, to be able to visualize. And after that point, you're pretty much treating it like a mini molar. This tooth in particular had some long roots. There was the lengths were about 22 millimeters after some occlusal reduction. And, I find that premolars are some of the trickiest teeth. They range in anatomy with 1, 2, and 3 canals. And the rate of 3-rooted premolars and a second maxillary premolar is less than 1% and about 5% in first premolars. Okay, and so we can go to the next one. So the second case I have is just a typical retreat case. I have the pre-op image on the left, which, it looks pretty good. It's number 19. We have 2 fills in the mesial, and then it looks to be 1 fill in the distal. But this tooth is called a radix entomolaris, which is also known as having an additional root. Typically, it's going to be an additional distal lingual root. And this was a retreat that we decided to do. It was through a ceramic crown that had a core buildup, and it had the untreated distal lingual canal. I'll go to the next slide in a bit, but I did take a cone beam so you can see that there's an area of pathology at the distal buccal and the distal lingual canals. There's a very minimal, if any, area on the mesial canals, but I had decided to retreat all 4. Again, same hints with this. You want to take angled PAs, follow the PDL. There may be a hint that there's, possibly an additional distal root on this one, but I had taken a cone beam. Once you're in the tooth, some hints you want to do is on the chamber floor, you want to follow the law of color change. And what that means is that the pulp floor is typically going to be darker. So you want to follow the darkness in this area. Another one is to follow the law of symmetry. Okay, so generally the canals are going to be in the center of the chamber, and the distal canals should be equidistant to the mesial canals. So in this case, the distal buccal canal that was obturated was pretty far buccal, whereas it wasn't in the center of the mesial buccal mesial lingual. So again, you're looking for symmetry. If the distal buccal is pretty far buccal, you want to start troughing lingually so you can try to uncover the distal lingual canal. In this case, it was very important to have a microscope to be able to see ample lighting, cone beam, and also I found ultrasonics and Munspers are really helpful in this case for brushing away dentin on the floor to look for that distal lingual. And we can go to the next slide where I have some of the cone beam shots. On the right photo, you can see that there's a distal lingual separate root. And typically the root is going to be smaller than the other roots. It can be separate or partially fused. And many of the times it has a severe curvature, as in this one is curving buccally. And there's also less than a 5% chance of this. So some of the specific risks and difficulties in this case is, you could get a separated instrument with the curvature. It may be difficult to negotiate the curvature and not to transport that root canal. And of course, perfing or perforation when you're looking for that distal lingual. In the right photo, you can see the 3 fills, the MB, ML, and the distal, and then the untreated distal lingual with the lesion. Okay, so we can go to the last case. The last case is a surgery case. It's an apicoectomy. This was number 30. And this tooth presented with distal root apical external inflammatory root resorption. So he had resorption on the distal root. It was previously treated and diagnosed with symptomatic apical periodontitis, meaning he came in with symptoms on the tooth. So the treatment in this case was an apical in the distal root. Some of the history, he had told me, the patient, he had the root canal treated 2 years ago by another endodontist. And he sent me the pre-op images from right before and after the root canal was done 2 years before. And at that time, there was no lesion in the distal root and there was no apical root resorption present. So in this case, we went over our treatment options, which would be a retreat versus an apical. And that's always important to consider, since he had told me he had this tooth treated by an endodontist and the fills look great, you really want to consider what can you improve if you're going to retreat this. For the retreat, some of the cons are going to be that, it could require multiple appointments in this case, to pull the fill, to medicate it, and then possibly to have the patient come back and refill the tooth. There, you have to access through the crown, which could always have a risk of the crown fracturing. And in this scenario, the main consideration was that you may not get a good apical seal because of the root resorption that's occurring in the distal. And then for the alternative, Apico, the main risk with Apico would be a risk of paresthesia from the mandibular canal. I took a cone beam in this, so I was able to measure how far the mandibular canal was from the distal root apex, and it wasn't in that close of proximity. There's always a recovery period of about, 4 to 7 days with some swelling. And you could get a little bit of gingival recession around the crown. So that's something I always discuss with the patient beforehand. The pros of an apico would be that it's done in one appointment. In this scenario, it would be more predictable in getting a better apical seal after we resect the root and then fill it with a bioceramic. So in the final image here, I had discussed with them how the resorption already created a shorter distal root. And then when you do the root resection, you want to resect typically about 3 millimeters and then retrofill with another 3 millimeters. But in this final image, there's actually BC putty in here in 2 canals that joined. And then we could go to the last slide, which is just a cone beam, some cone beam images. On the left-hand side here, we have a shot where you can see that there's the apical root resorption. So now the gutta perch is slightly extruded and there's an area around the distal root, whereas there was not an area around the mesial root. So I did not go in and treat the mesial root in this case. Another thing to consider on the left image, you can see on the left side of the tooth that's actually where the buccal cortical plate is. So in this root, the root was very close to the buccal cortical plate. So there's very little removal of bone that I would have to do to access where the apex is. With the cone beam, you also, you can measure how much you have to remove for length and the width of the root. And you also want to measure how far you are from any additional anatomy, such as the mandibular canal. And yeah, so like I said earlier, when we do the apico, we typically resect about 3 millimeters of the root. And the reason for this is that's where residual bacteria will tend to lie in the accessory or lateral canals. It's usually present in the apical 3 millimeters. We want to keep as much as we can to a 0-degree bevel, meaning you want to keep it pretty straight when you resect it, not angled. And then we retro-prep into the canal with an ultrasonic. In this case, I filled it with a bioceramic putty, and then you reposition flap and suture. Every once in a while, if the area of the infection is quite large that you had to remove, you sometimes have to graft and membrane, whereas in this case, I did not. Okay, so that was my presentation, and I'm open to any questions.
Yeah, so thank you for the presentation, Dr. Michelle. So we do have a few questions here in the Google Live chat, so I'll just read them out. The first question is, what about your specialty initially attracted you? And the second part to the question is, what experiences or people during dental school most significantly shaped your career path?
So what attracted me to it was that, when I first came out of dental school, I thought I wanted to be a general dentist. I thought there's no way I'll probably specialize. I like doing a little bit of everything. But then when I was in private practice, it would stress me out a lot if I was doing veneers or a crown or a filling, and the patient would come back with a little bit of cold sensitivity. I really took that home with me. Whereas in endo, the patient may come in with some symptoms and you're really taking those symptoms away. So that's what I really loved about doing endo. And it's also nice not to, like I kind of mentioned earlier, is that you don't really have to sell a treatment plan for endo. You know, if the patient's seeing you, they already know they need endo and they're ready to get it done. And so I did prefer that aspect of it versus general dentistry. You know, sometimes it felt a little bit like you were selling, you know, aesthetics or, you know, even Botox or whitening. And I'm sorry, the second part of that question was, who have I met during dental school that may have shaped my future?
Yeah, any experiences or people that have possibly shaped your career path?
Yes. So, you know, originally I always liked endo, even in dental school. This is a little just side note to that question, but I did have an instructor in dental school who I had mentioned that I liked endo. And her response, she was really big on implants, and she actually told me, don't do endo. The field is dying. You know, the future of dentistry is implants. So I actually, you know, put endo in the back of my mind. I was probably a third year dental student at that time and just didn't think I would ever go into the field. But then obviously when I got into GPR and private practice, I liked it a lot more. So that put me off of doing it for a bit. When I got into my GPR, I had one without specialties, so I was able to do a lot of the endo that came in. Our main endo attending or instructor was actually he was the program director, or he still is a program director of the endo program I went to. So he had the biggest influence on me, just because I really developed a relationship with him. I went and shadowed him in his office, and I was able to see, you know, his lifestyle, how his schedule was. And that was something that I, you know, really wanted to do. And that was probably a big reason why I ended up doing a second year when I said I had an optional second year for GPR, because I was going to be able to do more endos and apicos in that program with the program director. And so, yeah, he's my key influence in doing endo.
Okay, so the second question here is, what are the most common cases you see that are referred to you?
The most common cases are going to be molars through crowns, first time treatment, as an original root canal had not been treated before. A lot of them are, you know, even patients who just had their crown placed, you know, only 6 months ago, and then they started to get sensitive, you know, a few months after the crown was cemented. So that's probably what I do most of, trying to make small accesses through crowns.
Okay. So the next question is, when I shadowed an endodontist, they switched between asking for a short needle and a long needle for anesthesia. Is needle length a personal preference, or is there a reason to use one over the other?
So I typically use short for any maxillary teeth, because of the extent of where I need to inject for. Or if I'm doing mandibular premolars or anteriors, if I only want to locally numb the patient, I will use a short. I typically only will use a long needle if I'm doing a mandibular canal. Can you give me 1 second, actually?
Mm-hmm.
Okay, I'm sorry. Yeah, so I'll use a 27 gauge if long needle if I'm doing a block.
Okay. Um, what problems can what problems can root resorptions cause if left untreated?
So there's a few different types of resorption, right? If it's apical, you know, it's inflammatory. So there's a reason why that resorption is occurring. If it starts to deteriorate the apex, you're not really going to have a good seal. And because it's inflammatory in nature, it can progress. And, you know, patients may ask me, and for them, it could progress quickly in a matter of a couple months, or it could be something, you know, ongoing for a certain patient for a few years unchanged. But if you do start to see apical root resorption, you know, when that's occurring, there's likely inflammation and a lesion in that area. So you do want to initiate the endo. If the resorption, there's also, external cervical resorption, if it's at the cervical level, and also same, it's inflammatory. And you really want to catch it when it's smaller, because with cervical resorption, it can progress around the entire root surface. And you really want to catch it more cervically so you can seal it cervically rather than once it extends mid-root. With internal resorption, which is a bit different, you can still have a vital pulp. And so that's dependent on if the pulp is still vital, if it's already become necrotic, and how extensive it is. So something with like internal resorption, sometimes you can watch the internal resorption in some cases.
Okay. What is bioceramic putty used for?
Bioceramic putty is used, it's best used in, apicos when you're resecting the root and you're trying to get a good seal. It's biocompatible. So it has a high pH, and you can grow when you're doing surgery, the PDL and bone will grow against the bioceramic putty. It can also be used in vital pulp therapy when you're just amputating a portion of the pulp, and you can place the bioceramic putty or MTA on top to create a barrier and then put the restoration on there. I do that in cases for kids who may not be able to get a full root canal just yet, and we're trying to preserve the pulp as long as we can. I'll use bioceramic directly on the pulp in that sense, or on top of the chamber.
Okay. What does a rotary do?
Rotary, those are your files that you use with, the rotary system, and it works at cleaning and shaping your canals. So instead of, in the past, we used to hand file. With rotary, it's, activated, so you don't have to.
Okay. So let me just load up. Let me check if there's any more questions here. Okay. I think that was our very last question. So thank you again, Dr. Michele, for the presentation. We truly appreciate it. And I know that I learned a lot from your presentation. And to our viewers, remember that we have a quiz today that will stay up for 24 hours. You can find the link in our Instagram bio. And to Dr. Michele, thank you again for taking the time to talk to us today. And to everyone else, have a great day.
Yes, no problem. Thank you so much.